Wonderful. Well, hi everyone. My name is Dr. Gyles Morrison. I'm a clinical UX specialist. My talk today is on digital therapeutics, the future of healthcare. So a little bit about me. After working as a medical doctor for 3 years, I decided to change careers and go into digital health. For about the first 6 months of my role, I never actually knew about UX, but was doing a variety of UX work. And then it was in early of 2015 that I first heard of UX and realized that combining my medical experiences, medical degree with that is a wonderful opportunity to make a real difference for people's health around the world. So I've now carved out a career for myself as a clinical UX specialist, which basically means that I look at the user experience of clinicians and patients using healthcare technology and services and go through a variety of research, design, processes in order to create solutions that either make the working lives of clinicians better or the health outcomes of patients better. So, specifically about my topic today on digital therapeutics, I'm going to be defining what a digital therapeutic is, exploring what digital therapeutics can do now and certainly in the future, identify key features and considerations of effective digital therapeutics, review how digital therapeutics can revolutionize healthcare for all. Now, I won't actually have any case studies in this presentation because there's quite a lot of them already online. I want to focus more so on how we can utilize digital therapeutics with design thinking, with UX best practice and so on and so forth to actually improve healthcare for all, which is an extension of some of the stuff you might find in some case studies. With that said, I will have a slide that provides recommendations on some resources to help you learn a bit more. So let's get to it then. So there's about 4.8 billion mobile phone users in the world today. And when I say a mobile phone, I'm specifically talking about the back in the day Nokias that, they might have been able to connect to the internet, but no one was playing Candy Crush on them. But if you do want to play Candy Crush, there is in circulation of approximately 3.5 billion smartphones. And to put that into perspective, we're saying that about 61.5% of the world have access to a mobile phone, and just under 45% of them have access to a smartphone. This is like half the population of the world. This is a big deal. And then to support all these people, if they so wish, there's at least 320,000 healthcare apps on app stores. And when we talk about this number, it's actually relating to research done in 2017. And with the huge funding that has been money invested into digital health, where the global market for digital health is about 111 billion US dollars, it wouldn't surprise me if this number is dramatically higher now. But despite all of these innovations in healthcare, the uptake of mobile phones and smartphone devices, and so many talks that we have of innovations in general around the world, still there's massive health inequalities, problems that digital health simply is not solving, despite the potential being there. And to emphasize this point, I just want to highlight to you that actually more people have access to mobile phones than they do essential healthcare services. This is it's very, very painful truth that despite there technically being doctors or hospitals in countries, in cities, in towns even where people live, their ability to access that and actually maintain their health, that still can't be guaranteed for half the population of the world, at least. So what I want to propose in this talk, and by the end of it, hopefully you will agree, that digital therapeutics and the use of mobile phones can actually improve health outcomes for the vast majority of people. We might not be able to fully deal with the health inequalities simply by the use of digital therapeutics, but for sure it's a game changer. Now, I keep talking about digital therapeutics. It's probably worthwhile me even defining them. So a digital therapeutic, or DTX for short, is any evidence-based digital technology that prevents, manages, or treats ill health. So let's just break this definition down to be really clear and be in one accord about it. So it being evidence-based means that actually they can prove that they can do what they claim to do. And it's normally done through clinical trials, like some sort of scientific experiment for you to actually compare people who use the treatment versus those who don't. This is the most common gold standard way of assessing whether any type of treatment that clinicians are prescribing or endorsing would expect of a solution that they are prescribing or endorsing. And so put simply, if you can't prove your product achieves health outcomes, how can you guarantee someone will actually achieve a benefit with it? This is why it's so important to actually do clinical trials, because funny enough, people don't necessarily need facts in order to determine purchasing something. Particularly back in the day when the Apple App Store had healthcare apps in its own category back in 2008. There wasn't always bold claims from a scientific background why this app is going to help you. There's times it was just through great branding and marketing, and people being caught up in the moment that now they can finally download apps on their phone. It can be a health-related one, that they will just instantly trust it. And if it was as simple as people trusting facts and figures and statistics, well, they probably wouldn't have so many injustices in the world. Further to this then is that best practice medicine demands that any intervention, suggestions and tools, techniques, surgical procedures and the like that clinicians are supposed to be using, they expect it to be evidence-based. You want them to endorse it, get it evidence-based. The next then is prevention. So when we're talking about digital therapeutics preventing ill health, it means that someone is then either going to be prevented from developing a disease or actually having their disease progress and get worse. So you'll be surprised how many people actually don't know enough about their own health and how to maintain it. And so if you can provide advice and guidance, treatments from a trusted source other than a clinician, this is something that can lead to health benefits. And we'll talk a bit more when we discuss behavior change theory, why we need to think about trust when we're talking about someone actually changing their behavior and actually having their disease being prevented. So next area then is manage. So here we're talking about DTXs being able to manage diseases by providing treatment based on the current recorded data of the patient. Now that data could come from healthcare record in a hospital or family care, community care. It could come from the patient themselves, from the wearables or trackables that they're utilizing, and definitely from health questionnaires, which are really powerful ways of assessing patients' health. And we'll talk about that a bit later. The last one to cover then is treat. So then you treat diseases through education, lifestyle modification, and drugs. It could be anything in that realm. And you present it in a way that someone can absorb and respond to, and then they have improved health outcomes. And this to make sure we're all on the same page. When we talk about ill health, I'm specifically saying anything that actually leads to a state of physical or mental illness. Anything. So ill health is the direct opposite of good health. And just to answer your question, Sarah, I'm not advancing the slides just yet. You will notice that I have a lot of slides, but there's times we will linger on them. I don't want to have loads of text on the slides. So moving on. Why are digital therapeutics so important? So they're revolutionizing healthcare, whether we like it or not. And we're going to go through 10 main reasons why this is the case. So the first one then is that DTXs empower patients, helping them to take charge of their own health and making them more likely to become and stay healthy. They also lower the burden of care for clinicians. So clinicians can focus on the patients who really need their input and less time on patients who are actually stable or improving, and definitely less time on admin tasks. They also can improve treatment adherence to maintain effective therapeutic action and thus improve healthcare outcomes. They can provide care in new ways, helping patients beyond the capabilities of modern medicine or otherwise satisfy unmet needs. They complement other forms of therapy, enhancing their effect and improving healthcare outcomes when used in conjunction with each other. Digital therapeutics also provide personalized care, which users are more trusting and receptive of, and thus more likely to achieve great healthcare outcomes with. Then also, digital therapeutics support the collection and analysis of healthcare data, aiding ongoing analysis and subsequent optimization of healthcare provision. So we're talking about at a population health level, at a national level, even international level, you can actually look at what are the trends and patterns in how people are presenting with diseases, how they're responding to treatment, so on and so forth. And by observing that, you can draw conclusions how you can improve what's being done for them. Next is that they can reduce healthcare costs by treating and managing ill health sooner through less expensive means, if not preventing ill health altogether. This is a big deal. Like, if you can actually stop someone getting sick by reassuring them or getting them to change their behavior, not even having to involve any pharmacological intervention, and they don't have to see a healthcare professional to get their input, theoretically there would be no cost to that. But on the flip side, in a good way though, digital therapeutics are in a very, very lucrative global market. You know, the whole digital health market is approximately $111 billion this year of 2020. And also this year, the digital therapeutics global market is valued at approximately $3.1 billion, depending on who you go to for your source of truth. But, you know, regardless of that, I think there's definitely a huge opportunity here. There's already predictions that the digital therapeutic global market will increase in value by about 3 times, something along the lines of 11 billion in about 5 to 7 years from now. And I'm not surprised. You know, as we'll talk later, there's a lot of benefits that it can come from digital therapeutics when done properly. And then finally, digital therapeutics can reduce health inequalities by providing solutions that target vulnerable people, while still supporting those who can satisfy their health needs through other means, which is really important. You know, you want to be looking after people who are vulnerable. And as demonstrated here in this slide, that vulnerability could be from very obvious means such as disabilities of many kinds, but still at the core of big health inequalities is race. You know, me as a black man from the United Kingdom, even though I've been educated and I've earned a medical degree, statistically I'm more likely to die from a variety of diseases. So, what is needed to make a great digital therapeutic? In short, I would say that quality data and evidence-based interventions creating a solution that effectively improves health is what's required. Let's look at this in a bit more detail. So the first area I want to talk about with regards to what's actually needed to make great digital therapeutics are PREMs. So these are patient-recorded experience measures, which are patient-completed questionnaires, which assesses patient experience. And as I think most of you would have already heard of, patient experience is the experience that a patient has when engaging with healthcare services. And it could be anything. It could be actually speaking to the doctor, speaking to the receptionist before speaking to the doctor, actually the whole process of getting medication and the response they have to that medication, or surgical procedure, anything like that. And as I'm sure a lot of us have heard of both positive and negative patient experiences, and what we should also keep in mind is that actually great patient experiences do lead to people being healthier. They tend to heal quicker, have better responses to treatment if the overall experience in the healthcare service that they're engaged with is actually positive. And so digital therapeutics, they really need to respond to PREMs that could have been done for other products or other areas of the same disease that they're treating, and definitely within the product itself, so that there is this feedback loop. If there's anything that's good that's going on, keep doing that. If there's anything bad, then consider removing that, or at least improving on it. Next then are PROMs. So PROMs are patient-recorded outcome measures and are evidence-based healthcare questionnaires which identify change in health status. So put simply, if you fill in one of these PROMs, it could be for a specific disease, it could be a series of diseases, like a constellation of them, so assessing risk related to depression and then suicide risk, so on and so forth. Or it could just be for chronic diseases like diabetes or inflammatory bowel disease. You will fill in one of these PROMs, and by the end of it, there will be a score that's generated, which will tell you, is this patient stable or are they deteriorating? Or even better, in comparison to previous scores, are they improving in their health status? Now, this is really, really powerful in digital therapeutics, because this, combined with very simple decision support tools that could be AI driven or just simple algorithms, will allow clinicians to quickly understand who amongst their patient base do they need to be worried about and start targeting treatment, otherwise interventions for, And further to that, with the decision support tools, is what could be the best next steps. And it's not to remove the decision-making process from doctors, because as a doctor myself, I know full well that we want to be able to use our training to heal people. But thinking is quite dangerous. Like, thinking is liable to make you make mistakes. And thinking is also quite a slow process. In emergency situations, you don't want to do that. So you want to remove thinking. You want to enhance the ability to act. This is not the same as people not making decisions. You know, acting requires a decision, but it's a thinking process. We need to support clinicians in being able to speed that thinking process up. So let's keep moving on then. Clinical best practice. This is where we combine clinical pathways and care plans and use them in conjunction to understand how best to treat patients throughout their journey as a patient. Now, for those who aren't so familiar, a clinical pathway is any evidence-based patient care management tool detailing the best way to treat a specific group of patients with a predictable clinical journey. So for example, if someone says that they're feeling tired, they're noticing they're going to urinate a bit more frequently than usual, and that their parents also suffer from diabetes, there's a strong chance that that person has diabetes. It might be type 1, it might be type 2. So you can't just get that information just from those limited information. But a clinical pathway would then dictate that you would do a urine dipstick to see if there's any glucose in the urine. You know, you might do some further investigations, some blood tests. You know, you take more questions, you do some examinations to get to that differential diagnosis, which may prove or disprove that this person has actually got diabetes. And now the significance of this is that once they're on that clinical pathway, there will be subsequent steps that that patient could go down, particular paths that they could go down. That's already been planned, and it's evidence-based on what's best to do for them. The digital therapeutics should be keeping this in mind in order for it to be effective. And further to this, you then have care plans, which are specific instructions for care for a patient. They can be unique to the patient, of the categorization of the patient's disease and health status. And it can be even more personalized, even to a genetic level for that individual patient. So you want to be using clinical pathways and care plans to make sure digital therapeutics are really putting patients on the right path to improving their health. Regulation is the next big area. You know, as mentioned before, you need to be evidence-based. You need to be able to back up what your claims are for your digital therapeutic. And to support with this, you'll find that virtually all DTXs are considered softwares as medical devices. Now, what that means is that they are being treated as something that's not a medical device in a physical form, but in a digital form. They're being seen still to the same regulatory requirements and held to those as medical devices. So we're talking about surgical instruments, any equipment that could be used for around the hospital or in otherwise in healthcare settings. You know, they have to work, they have to be able to prevent harm as much as possible. So this is the realm of ergonomics and human factors, and also for them to actually lead to successful health outcomes as well. So not just the do not do harm part, but actually help somebody part. Both of those are equally important. And so by being regulated, it means that there will be a clinical validation of that digital therapeutic, and that they uphold GDPR, or depending on if you're outside the EU, whatever privacy or security laws govern that land. Next then is behavior change theory. Now, this is one of the biggest areas in digital therapeutics, which you really need to get right. Like, it's not really tolerable to get wrong on, you know, a couple of main levels. The first one is that behavior change theory ultimately is about applying practically understanding and knowledge of what can determine a human or, you know, animal's behavior. It's not just humans that enact behaviors, animals do it too. And now, you know, it's really important to think about this, because that's what you're doing with the digital therapeutic. You're actually instigating behavior change. So just think about it. Digital therapeutics are generally designed to reduce, if not remove, the need to see a healthcare professional. Now, going to your mobile phone for, you know, your common healthcare needs instead of a healthcare professional is a massive behavior change. This is not normal, especially for certain people of the population who aren't comfortable using digital technology, may not even own a smartphone device. Telling them to dramatically change the way that they seek health could actually prevent them from seeking health and make themselves vulnerable. Now, there are a variety of behavior change theories out there, The big ones that come to mind would be COMBI, the reasoned action approach, and the FOG behavioral model. So next then, which shouldn't be too shocking to an audience at the UX Healthcare Conference, is best practice UX. And this ties in a lot with the behavior change theory piece, is that, you want someone to not just download an app or download a service or even just sign up to it. If it's not even a digital solution, you want them to actually engage with it as well. Not just responding to notifications, but perhaps even instinctively developing habits that leads to them engaging with the app themselves or engaging with this new health promotion themselves with very little prompting, And so it's about applying best practice in UX, which includes utilizing the most appropriate research methods, going through an iterative design process. You should be doing usability testing and actually making appropriate amendments to your design solutions where appropriate. And then when it's launched, test it again. Now, for most UX professionals, this would involve user-centered design, or what others like to call human-centered design. But I actually had a really wonderful chat with Don Norman about this. And he planted the seed and opened my mind to the concept of people-centered design, which probably a lot of us have already heard of before, but not necessarily discussed or even championed at work. And so I would like to just plant this seed for others as well. So people-centered design versus user or human-centered design, is still obviously keeping the patient, in this case is the chief user, the chief human, at the center of the design process, but it's also keeping in mind the needs, wants, and limitations of other significant people at the center of the entire design process. What do I mean by that? I mean that the patient has loved ones, has maybe a carer, has friends, relatives. That patient also has clinicians that need to know what's going on with their health. That patient needs to be served content that has to be continuously provided by people working with the app, assuming it's a digital therapeutic, for example. And these things need to be kept in mind in order for you to actually create a product that helps the service that wraps around the digital therapeutic and the ecosystem that digital therapeutic fits into. So how can a digital therapeutic improve health for all? In short, you need to focus on those with the greatest need. And these are going to be vulnerable people. Now, a good way to try and understand vulnerable people as a UX designer is this concept of a limiting user. So we briefly touch upon this then. So a limiting user is any legitimate user who may have difficulty engaging or achieving a goal with a product or service. So let's just explain this point through a worked example. We have a washing machine here, and we have a young teenager called Tim, okay? So he's someone who could use the washing machine. He's a teenager, he's more than old enough to know that when his drawers are stinking, he needs to put them in the washing machine and clean them. No one else has to do that for him. He's a legitimate user. But then we also have Pippa. She's a limiting user because she has to use the washing machine. She's now, she's more than capable of looking after herself, even though she's a retiree. She's not so old she can't do stuff anymore. But she does have rheumatoid arthritis that's getting on a bit. And because of that, it means that her pressing the open door button, which is really, really firm on most washing machines, she struggles with that. So she's going to have issues, but she's a legitimate limiting user. But then we have 5-year-old Laura. Okay, she should not have the ability to give her cat a bad hair day by putting him in the washing machine. She should be incapable of opening the washing machine. If she could open the washing machine, she becomes an abuser, okay? This is another definition of abuser that I haven't made up. A lot of people aren't always realizing it. Abuse is also improper use of something, okay? She's not a legitimate user. So applying this then to the vulnerable person, a vulnerable person is any person who fails or is at risk of failing to have their basic human rights protected. And I want to primarily focus on the human rights relating to the right to good health. So let's explore this a little bit then. So we've got the disabled, which aren't as obvious as someone in a wheelchair. People with sickle cell anemia are disabled. People with cystic fibrosis, with inflammatory bowel disease are disabled. People who are partially sighted but wear glasses or even have a walking stick, they're disabled. And there's times they might not have their walking stick when you see them. It doesn't mean they're not disabled. There's many times where people have disabilities that can't be seen. They're vulnerable. They might have health needs that are not being addressed because no one's recognizing that they need help. Someone who's homeless is going to have health needs associated with not having a fixed abode. They may not actually have a mobile phone as well. So they then deteriorate, no one can contact them, no one's going to help them. They're at a very bad state. And further to this is the impoverished, those who are too poor to feed themselves appropriately. And it's not through their own, laziness or decisions to not be educated, it's lack of opportunity. When you provide opportunity to people who are impoverished, they can thrive, You need to give them job, you need to give them education. Then we're looking at the abused. And in this case, I'm talking about someone who may be suffering from some form of domestic violence. And we see a picture of a woman in here who is supposed to represent someone who's isolated, but it can also be a man. And if you are someone sadly listening to this and you feel like you're being abused or you're actually abusing someone else, you don't have to stay silent. There are services out there that can help you. And it's important that you reach out, even to a healthcare professional, social services. There's support that you can get to change that. Then there's the elderly, which comes quite obvious. I'm sure we've all had either grandparents, great-grandparents, or heard of, very elderly people who they've lived many, many years very independently, but perhaps they've had a fall or something else has happened to them, which means that they're just not able to do as much for themselves. And so you need to keep in mind what can be done to keep these people healthy. They don't use technology as much. You can't just say, go on the internet for more information about how to have prescriptions automatically sent to your door. If they don't own a computer, don't own a smartphone device, and even their mobile phone, they never touch the internet settings. Then there's asylum seekers. And asylum seekers are very much vulnerable people. They're citizens of the world, but if you're not a citizen of a country, you can easily be denied healthcare. Like in the United Kingdom, where I'm from, actually, if you don't have a right to be in the country, you can get emergency care, but life-saving care at times will be denied. And as we know as well in the US, if you don't have health insurance, you can be in serious, serious trouble. Then there's the expecting mother. And I'm also wanting to focus on the unborn child who's completely dependent on the mother, and any vulnerabilities that the mother has and any illnesses, ill health that she has will have detrimental, if not fatal effects on the unborn child. And further to this is the young. We're talking about anybody who is still dependent to be fed, to be clothed, to be housed. And this kind of doesn't end apparently until you're about 18. So there's one last area of people who are considered vulnerable. And this is actually those who don't seek healthcare services. And actually this could be anybody. Like there's great assumptions that we make about people who don't report to healthcare professionals soon enough. Sometimes it is laziness. Sometimes it's denial. Sometimes it's this false belief that they're virtually immortal, nothing can happen to them. But it also can be genuine fear. They've had bad experiences themselves, or they've seen something terrible happen to a loved one and they don't want to experience that again. As much as it goes against logic, it's not a logical response that they're making, it's an emotional one, which is a human response. And we need to keep this in mind, that there are people who don't seek healthcare services who deserve to be healthy as well. And unfortunately, digital therapeutics tend to focus on people who are already quite healthy. It becomes an area where, particularly with investors of the digital therapeutic companies, they want to focus on those who are wealthy, educated, and understand the benefits of their digital therapeutic, and therefore are more likely to pay for it. But actually, I'm not worried about someone who's regularly doing yoga, probably on a vegan diet, ready to climb Mount Kilimanjaro, using healthcare apps regularly. They are probably very healthy, hence why they do those things. I'm worried about someone who's already obese or thinks that it's very difficult to be healthy, who doesn't really know how to have a very good, balanced, healthy diet, even if they're on a low income. Someone who is quite passive about health because they're a bit fearful of it, of seeing healthcare professionals, or because they don't really have very serious health symptoms, so they think it's not that important. But they're using mobile phones. It's not like they don't have access to the information, but you need to give them the right motivation. You need to think about the behavior change that you can enact that can motivate them and activate them to do more for their health. So to explore this in a little bit more, I want to talk about a scenario that is semi-true. So just from my upbringing as someone from Jamaica, and I think a lot of people who are of African descent as well can relate, when you have an elder that's around you and they're female, you call them auntie. So here's Auntie. I do know for a fact, though, that she is a weaver, and she's weaving in her home in this picture. And she lives in eastern Nigeria. Now, I would imagine that, considering the sort of living conditions that she has, that there may be other issues with seeking healthcare provision. There might be issues relating to cost or even physical access to that healthcare professional. So despite her potentially using a service like M-Pesa, which is a digital bank service, financial services, which is completely controllable with a mobile device, not smartphone device, mobile phone. She can use an SMS to actually say that she wants to transfer money to somebody else that also uses M-Pesa. She can take her mobile phone and with the right codes, go to a stop that supports it and draw cash from a shop rather than from an ATM. She doesn't need a debit card. She doesn't need any more sophisticated technology than that. I would love to live in a world where we can think that digital therapeutic in this realm would mean simply combining a service like M-Pesa, where she can explain her symptoms by SMS to the right number. She gets a response back. This then triggers a prescription. And then actually, she can get medication paid for just using her mobile phone. We take for granted how many of us probably have a banking app on our phone and can transfer money and pay for things on Amazon and using PayPal and eBay and the like. There's a lot of people in the world that can't do that until M-Pesa came along. We need to also see how can we get people to have that sort of control over their lives, not just for money, but for their health. So what's the next step then? The first thing then, what I like to call the 3 CTAs. As a UX designer, I like to have good call to actions. Anyway, the first one then is a call to accept. We've got all these people who are vulnerable, who deserve and have been born with the right to be healthy. We need to accept this fact and accept them amongst the people who we need to protect and look after. Okay? They were born with this right. They shouldn't be denied it. And with this acceptance, we can then respond to the call to action for all of us as global citizens to actually look at what can we do to actually change the health inequalities that we have. And I would hope that this talk can be a call to arms to fellow UX professionals who can use their skills, their training, their experiences in conjunction to actually create these digital therapeutics and other solutions that can reduce these health inequalities and keep the world a happier, healthier place. So finally, a few resources that you can find out more information about digital therapeutics. First and foremost, it would definitely be the Digital Therapeutics Alliance. Just go to dtxalliance.org. You can also find a few articles done by mckinsey.com on the promise of digital therapeutics and Evidera on digital therapeutics, past trends and future prospects. And then finally, there's a wonderful PDF that I managed to find online called Digital Therapeutics, Improving Patient Outcomes Through Convergence. It's been a pleasure talking to you. Thanks for listening. Please stay in touch. You can find me on LinkedIn. You can find me on Twitter. You can find me via the somewhat, not quite snail mail anymore, but it does feel like a slower way to get through to me, which is email. And of course, to find out more about the work that I do on promoting UX in healthcare and encouraging others, such as UX designers, clinicians, and other IT professionals to make changes, please head to clinicalux.org.
Fantastic. Thank you so much. Can you hear me, Doctor?
I can, yes.
Perfect. Okay. So we're just waiting. If anyone's got any questions for him, we've got about 10 minutes before our next session starts. So if there's any questions, please pop a question over. There's a tab at the bottom that says ask a question. I did have Jessica, who's also based in Germany, wanting to know where you're based.
Yeah, so I'm based in a small town called Badenheim. It's about an hour's west drive from Frankfurt. Really wonderful place, full of vineyards. I don't drink any wine, but I like grape juice. So it's a very nice, peaceful area.
Perfect. And tell me, what's the mandate for CUXA?
So the CUXA really is a global community for clinicians, UX designers, IT professionals to involve more UX in the design of healthcare technology and services. And it's supposed to be a leading voice on actually doing that. So we've had events over the years in London, in South Africa, in the US, in South America, that's really rallying these people together. So we've been a bit quiet over recent years, but we will be having a formal launch in the fall, as you guys in the US would call it, or autumn for the rest of us, this year of 2020. And that will be abilities to get more articles, more opportunities to learn more about UX in the context of healthcare, and my specialist subject of clinical UX, so UX for healthcare professionals and patients.
Fantastic. So look, I do have a question, and I'm sure this question is probably going to come up during the course of the day.
Mm-hmm.
Does CUXA or put them in contact with clinicians, or how do you go about getting in contact with clinicians? Because I do know as UX practitioners, I think that's a large part of when you're developing a platform for healthcare to be able to test your product on clinicians. So how do you advise people to actually go about that?
Yeah, so I think you have to really go to where the clinicians are. That doesn't literally mean go to the hospital and rock up when you're not sick, like especially during a pandemic. That's not a very good decision. But clinicians that are interested and very willing to help you will make themselves known. Like very often you might see on LinkedIn they've got a job title of digital health consultant or digital health advisor, clinical advisor, something like that. There's also groups that you find on Facebook. One of them in particular is the Digital Doctors Collective. That's a really great way of coming across doctors who will be willing to help out with testing. It's not just people in the UK, even though it was many UK-based doctors, including myself, that set up that group. But you can find them all around the world now. And the other thing as well is just even put a post on LinkedIn, tag me, tag a few other people that are doctors, and they will come, like the clinicians that are interested. And of course, there are market research companies that will help recruit clinicians, so there's a fee associated with that. But if there's budget, that's a great way to get clinicians on board as well. Hopefully that answers your question.
Neat. Yeah, it does. It does. Thank you so much. So you'd advise social media for sort of platforms that need to hang up. I think something as well is that clinicians are also quite busy.
They are. That's why they can be more receptive if you're going to pay them. But also, if they're already interested in healthcare, UX or digital health in general, then they normally are making themselves known. So if you are putting stuff on Twitter, you're writing articles, you're doing podcasts and stuff, these clinicians will actually gravitate towards you, especially if you make it really clear that you need clinicians. But it does take time.
Agreed. Okay, so we have one question here from Sarah, and Sarah's saying, she does not have a medical background, but what type of training do you recommend in order to succeed in DTX? Yeah,
there's quite a few areas. So DTX falls within the realm of clinical UX. And as mentioned before, the big things you need to understand are clinical pathways and care plans. You need to know about appropriate prompts for the disease that your digital therapeutic is treating. And these are things that you can find in some shape or form online on your own, but it's going to be labor intensive. Having a clinician on board to open your eyes to that can help. I personally can also help out. If someone reaches out to me and they want some advice or guidance, or if you need to be doing your project, feel free to reach out to me, or I will know someone within my network who could also help you as well. There actually isn't any proper clinical UX courses out there. There's some opportunities to learn a bit about UX within the healthcare space at master's level, but it's a bit too superficial. So again, this is something that I'm exploring, is opportunities to teach more people about clinical UX. So again, if that's something that you're interested in, Sarah, please do reach out to me and see how I can best help you.
Dr. Morrison, thank you so much for that. I really appreciate it. Very informative as usual, and very helpful.
Thank you.